the induction of anesthesia, which was called as your pre-anesthetic group of drugs. So after that, there will be a process of induction of the general anesthetic drugs, and that will be induced at a very rapid. The drugs are selected in a such a way that they show the rapid onset of action, and that will be only possible through your intravenous route of administration. So after that. Now the fourth step would be your maintenance of anesthesia, which will be now done with the group of the inhalational anesthetics. Okay, so your inhalational, as you can see in the figure also, so this is kind of your uh, thing use masks or because these are in the form of gases or volatile liquids here, the way through which they can reach to the patient is through the use of masks. Okay, so inhalational anesthetics are mainly used for the maintenance of the anesthesia after your administration of intravenous agents. Now, this is the general pathway for your inhalational group of general anesthetics. Okay, so since these are in the form of your volatile liquids or in the form of mainly the gases, okay, so they will be inspired along with the inspired gas mixture, so they will reach the lungs. Okay, so this is the pathway followed. So from the lungs to from the lungs they will go to the blood, and blood from the blood they will go to the system, and through the system they will reach various tissues. And since the brain is one of your highly profuse organ in the body, so they will be reaching the brain at more uh, rapidly in this area or the body, that is the brain. Okay, so this is how it acts on the brain. And we now already have discussed about the mechanism of action, that how they will act on certain receptors like NMDA receptors or even your nicotinic acetylcholine receptors there, and bring about the unconsciousness in the patient and abolition of all the reflexes like your pain reflexes, your somatic and autonomic reflexes and all like that, you know. So when these are withdrawn also, when the inspired when the inhalational agents are withdrawn, the same path is then followed. Okay, so from the brain the withdrawal will be occurring into the venous blood, and from the venous blood they will be entering into the alveoli, and along with the expired gas mixture they will be thrown out. Okay, so this is how the thing is going on. So your thing different from your intravenous group of general anesthetic is that you have to know about certain pharmacokinetics or certain characteristics of the inhalational agents that is not there when we have studied the intravenous agents. Okay, so we have to go through the thing called as the MSC, which is your minimum alveolar concentration, then blood gas coefficient ratio, then you have to know about thing called as second gas effect, and the fourth one is your diffusion hypoxia. Okay, so coming first with the minimum or the median alveolar concentration or the MAC value. So this is if you remember your general pharmacology classes, there were certain thing called as potency of the drugs. Okay, so same is that which is the same thing, that is the potency when applied for your inhalational general anesthetic drugs, they will be called as your median alveolar concentration. So you can just relate this thing, the MAC value, with the potency of the drug. So if you remember the thing called as potency, it is nothing but it is the lowest concentration of a drug which is there to produce certain effect, you know. So there was potency and efficacy, so you have to apply the same thing here for the MSc value. Okay, so MSc is the lowest concentration of the anesthetic, that is the drug, in pulmonary alveoli, that is needed to produce immobility. So immobility is your response here. So it is the lowest concentration of the anesthetic in pulmonary alveoli that is needed to produce immobility in response to a painful stimulus in 50% of the individuals. So this is same as that of the potency of a drug, which is the lowest concentration needed for certain drugs to produce any of the effect. Okay, so you can say that numerically your MAC will be the index of a potency, but that is true only for your anesthetic group of drugs. We will not be saying MAC for any group of the drugs. These are mainly true for only your which group of drugs? Your inhalational general anesthetic drug. Okay, and the thing is that because we know that most of the drugs that are lipid soluble in nature, so when the drug is more of lipid soluble, your lower concentration of the drug will be needed to produce the anesthetic effect, and therefore lower concentration needed means there will be higher potency of the anesthetic. That means to say, if the MAC value, these are the numerical value, if they are assessed numerically, okay, so if they have greater MAC value, that means there will be lesser potency of the drugs. So is that clear?
Yes, ma'am.
So, for example, we have in this slide we have listed the MSC value for different inhalational. So this is only for inhalational, okay, not for the your intravenous one. So we are here saying that a halothen, a group of your inhalational anesthetic, have a MSC value of 0.74, whereas you see nitrous oxide, they have the highest value of 104. So what can you say from this numerical value? Which one will be more potent and which one will be less potent?
Halothen is more potent.
So halothen will be
More potent.
More potent because the MSC value is less, whereas nitrous oxide has MSC value more. That means your potency will be less. Means less potency means you have to now use more of the concentration of the drug to produce that effect. Okay, so you just have to relate this with the potency of the drug. That is all with the MSC value. So next is your blood gas partition coefficient. Okay, and this is the useful index for the solubility of the inhalational drugs. So as I said that most of the drugs, they are lipid soluble in nature. Okay, so this part your blood gas partition coefficient will be an useful index to let you know how faster the drug will show their action or how late they are going to show their action manera. Okay, so blood gas partition coefficient, as you remember the pathway that I have shown, the, from the inspired gas mixture, they will be entering into the alveoli, and from the alveoli they will go to the blood compartment, and likewise. So you want to go, it is the relative affinity of a drug, that is the anesthetic drug, for the blood, first the blood, okay, compared to that of your inspired gas. Okay, and this is a very useful index which will determine your onset of action for any particular inhalational drug. So, for example, your halothen has a blood gas partition coefficient of 2.3, or let's say around 2.4. And you see, when compared with nitrous oxide, they have a blood gas partition coefficient ratio of about 0.47. Okay, so if you see here also, so 2.4 and nitrous oxide is 0.47. So that means, okay, your it is the concentration in your blood versus your in the gases mixture. So that means to achieve the equilibrium, whenever like to achieve a steady state or to achieve a kind of um, a threshold when the drugs will act, okay, in that equilibrium, what is there is that the concentration of halothen in the blood will be 2.4 times that than that of in your gas. Okay, so that means this will be a highly soluble gas that will be remaining in the blood for a longer time, whereas your nitrous oxide, okay, to achieve the equilibrium or the steady state to show the onset of action, it only requires 0.47 times the value, okay, 0.47 times the value in the blood than in compared in the gas. That means this will achieve more faster onset of action rather than your halothane, which have a higher blood gas partition coefficient. So that means when a drug they have a higher blood gas partition coefficient, it means that they are more soluble in blood and they will be remaining in the blood for the longer time, okay, compared to the gas. Okay, so that means there will be lesser chance of showing the faster onset of action compared to the one which shows the lesser blood gas partition coefficient. So am I clear, or is this difficult to understand? Is this clear? So it is just a concept that your blood gas partition coefficient is your index for solubility of drug, and it will determine how faster the drug will act or show the action manera. So the one group the drugs that are having your more blood gas partition coefficient means, okay, they will be more soluble in the blood. That means the faster, or they will be not showing the they will show the slower onset of action, whereas nitrous oxide, which has your blood gas partition coefficient is lesser, means less soluble in blood, so they will be entering into the other compartments more easily, tissues but they will enter more easily, and they will have the faster onset of action. Is that clear? Am I clear?
Yes, ma'am.
Okay, so that is all the things that happen that is explained in the words here. So anesthetic with high blood solubility, that is your they have the blood gas partition coefficient about 2.4. Halothane dissolves more completely in blood, and therefore greater amounts of the anesthetic and longer periods of time are required to raise the arterial partial pressure, that is to attain the steady state. Okay, to attain the equilibrium it will need longer time, and therefore they will result in increased times of induction as well as recovery, and that is kind of opposite for the drugs which have kind of your a lesser BZ coefficient, like for the nitrous oxide, which will show the faster onset of action as well as recovery. So this is again shown in the figure here. Okay, so nitrous oxide, because they have the blood gas partition coefficient less of about 0.47, okay, they will not remain in the blood compartment for the longer time, and therefore they will show the faster onset of action, whereas in contrast halothane, there will be more amount of halothane being there in the blood compartment, okay, for a longer period of time, so therefore there will be slower onset of action and slower onset of recovery also. Okay, okay. So now coming to the specific and important inhalational anesthetic drugs, first is your nitrous oxide. So nitrous oxide drug, it is along with the anesthetic action, it also have a analgesic effect. So the need for further addition of the analgesic drugs will be lesser during the course of surgery. So they also have, we have discussed this just now, that they have rapid induction and recovery. So to which property of the drug will you relate to this for the rapid induction and recovery? Which property will tell you about the rapid induction and recovery of the drug?
Blood gas partition coefficient.
Yes, blood gas partition coefficient. They have lesser blood gas partition coefficient, so they will remain in the blood compartment for the lesser time, or lesser amount or concentration of the drug will be required uh, in the blood compartment, so they will have the rapid onset of action as well as recovery. So no adverse effects on CVS, respiratory, kidney, and liver, which becomes an advantage for this group of drugs, and also they don't have a potential of causing the tachycardia or bradycardia. So fluctuations in the blood pressure and the heart rate will also be not there along with the use of nitrous oxide. So, however, the disadvantage with nitrous oxide is that they are less potent. So, what do you mean by less potent?
Higher dose is needed.
higher doses needed. That is, they have higher MSC value. So when we need to produce the anesthetic effect while using only the nitrous oxide, we need more and more concentration. Again, more and more concentration means it will invite for the unavoidable side effects that is there with the nitrous oxide. So there is also no bronchodilation cause here. So the use for nitrous oxide is mainly because they have the MSC value uh, about their because they have the less potency. Okay, they are not used as a sole agent, but they are used mainly as because they show faster onset of action and recovery. Okay, they will be tagged along with the other. Group of the drugs which are highly potent in nature, like your halothane. Okay, so they will be acting, they will be tagged along with this drug, so that nitrox oxide, when they go inside the alveolar phase, okay, they can carry the other drugs along with it, so that other drugs which have the disadvantage of having the kind of slower onset of action like halothane, they will now can act more faster when they are combined with the nitrous oxide. So that means that they are used mainly as a carrier and adjuvant to another other anesthetics. Mainly they are combined with drugs like halothane, and they also maintain surgical anesthesia in combination with oxygen and other volatile anesthetics. Okay, but they are mainly used solely for the dental purpose as a sole agent. Okay, where they are used as a sole agent for producing anesthesia. So coming to the adverse effects, they mainly cause megaloblastic anemia and the expansion of pneumothorax. So next drug is your halothane, which is a potent anesthetic. So potent anesthetic means, okay, so there will be lesser concentration required to produce the same effect as that of the other inhalational agents. So compared to the nitrous oxide, these are bronchodilatory in nature, so they can be preferred in the patients who are asthmatics. But the disadvantage with the halothane is that they show slow induction and recovery. Again, this is because of their blood gas partition coefficient ratio, which is high. And this is not a good analgesic or muscle relaxant. So, along with this drug, you need to combine another analgesic drugs and muscle relaxants if you did that during surgery. So, they are mainly used for maintenance anesthetic, as we all know, and they are mainly used for a pediatric anesthetic drug also. So coming to ADR, they mainly cause they are mainly hepatotoxic in nature. So they can be hepatotoxic by a direct toxic effect, and also through your immune response produced by metabolites from the metabolism of the drugs that we have already discussed in the part called as your hepatotoxic drugs. And then you have separate, you have had the separate chapter in the GI block where you have been taught about the hepatotoxic drugs. So you can just go and revise how the halothane hepatitis is caused. Okay. So next is main important thing that you have to remember with halothane is that they are a potential drug of causing the malignant hyperthermia. So this is the side effect that you must learn and you must know about for the halothane. So what is it? Bandaheri, this is a kind of heritable uh, kind of side effect. You cannot see the side effect in every individual, but there are certain group of the genetic individuals where your malignant hyperthermia can be seen. So what happens is in the sarcoplasmic reticulum, there will be a kind of storage for the calcium. Okay, vesicles is there. So there is a abnormality in a receptor known as a ryanodine receptor that is controlling the release of the calcium from the sarcoplasmic reticulum. Okay, and when this thing is abnormal, there will be more release of the calcium into the cytoplasm, and when the cytoplasm concentration will be very much high, there will be um, consequences like there will be more rigidity in like muscle contraction, the temperature will rise, and there can be acidosis and all the consequences which can even be fatal. Okay, so this is called as your malignant hyperthermia. Now they can also have a arrhythmogenic potential. Mainly they cause bradycardia, and since they are hepatotoxic drug, okay, they are to be contraindicated in a liver disease. Next drug is your isoflurane. Okay, so they also have a rapid induction and recovery. But rather than isoflurane, your kind of your nitrous oxide is mainly used as a carrier gas for the other drugs which has slower onset of induction and recovery, like that of halothane. Now, they cause also the precipitation of regional myocardial ischemia, which is known as coronary still phenomena. So, if you remember in your angina classes of your first year classes, okay, so there is this phenomena where drugs can steal away the blood from the affected area. I know. So that thing is also true for your drug called as isoflurane. Okay, and now they are mainly used for neurosurgeries. And since these are vasodilator in nature, they are bound to cause your effect like your hypotension. And as a reflex to maintain that hypotensive effect, as a reflex, there will be a reflex tachycardia. So they don't they are not used for conditions like cardiac arrhythmias, which is an absolute contraindication for the drug. So next drug is desflurane. Again, they have your rapid induction and recovery. So they also have the lacking of seizure provoking potential. Okay, so they can be safely used in the patients of epilepsies, and also they are not arrhythmogenic in nature. But however, they are irritant to air passes. So when a drug becomes an irritant to air passes, they can induce coughing and all, you know. So breath holding can occur and laryngospasm can occur. And also because of these things, your aspiration to the aspiration of the gastric contents to the to this airway tract can be possible. Okay, and okay, because of that thing, um, they are mainly used for your outpatient surgeries where your surgeries are of like where you can complete the surgeries in certain uh, lesser time, and the patient can be recovered in the same day. Okay, so because uh, and the ADR includes breath holding, apnea, coughing, and laryngeal spasm, and also they can cause post-operative nausea and vomiting. Okay, so because of this, you can use the pre-medication, pre-anesthetic medication. What kind of pre-anesthetic medication can be used to control this kind of ADRs associated with this fluoride? We have kind of discuss this in the pre-anesthetic medication, that to reduce the side effects of the general anesthetic or drugs also you can use the pre-anesthetic medication. So to control post-operative nausea and vomiting, which drugs can be used? What are the name of the drugs?
Antiemetics,
What is the name of that drug?
metoclopramide,
Ondansetron and all. Okay. So next drug is sevoflurane. So again, this all fluorines have, if you know, if you have noticed, the drugs fluorine, that is isoflurane, sevoflurane, desflurane, they all have the rapid induction and recovery. Also, they have a good muscle relaxation properties. If you need during the surgeries, the relaxation of muscles and all, you don't need to add another skeletal muscle relaxant drugs. That will be an advantage to the use of sevoflurane. And also there will be absence of seizure and arrhythmia, so no bradycardia or tachycardia, and even can be used safely for the patients of epilepsies also. But however, they cannot be used in asthmatics. They don't have a bronchodilating property, but they may trigger the malignant hyperthermia. So which of the drug was associated with the adverse effect malignant hyperthermia? Which was the drug that was mainly associated with malignant hyperthermia?
halothane.
Halothane. Okay, so they are used for outpatient as well as inpatient surgeries, that is major surgeries. And now they can cause shivering, nausea and vomiting in post-operative period, and hypotension. Uh, so now there is a thing, I have listed some of the things that you have to learn, Manera. So that was MAC, then that was B, blood gas partition coefficient ratio, then there was second gas effect and diffusion hypoxia. Now we'll be talking about second gas effect. Now, as I've told you that one of the main uses of nitrous oxide is used as a carrier gas. Okay, that because they have the faster onset of action as an advantage. Okay, this advantage can be utilized for the drugs which have the slower onset of action, like your halothane. Okay, they can combine together so that the nitrous oxide can carry the halothane along with it, so that halothane can also now show the faster onset of action as compared when they are used alone. So the MSC of halothane required to produce anesthesia is reduced when given with nitrous oxide because of second gas effect. So this effect, when you use or combine two drugs together, which can kind of assist each other's advantages and disadvantages, is called as a second gas effect, because you are using two gas together uh, to make sure that the other gas has the same advantage of having the rapid onset of action as that of the nitrous oxide, so that it's called as a second gas effect. So in that way, what can happen is that the side effects that is used that is there when they are used will be reduced. So what is second gas effect is more um, in a simple words. Okay, your nitrous oxide rapidly diffuses, whereas your halothane diffuses poorly because they have slower onset of action. But when these two gas are simultaneously administered together, okay, so halothane also enters the blood rapidly along with the nitrous oxide. So it is like your it acts as if like your nitrous oxide, the gas is carrying the halogen along with it, and therefore this is like there is a second gas along with it. So this effect is called as your second gas effect. Okay, so next is your diffusion hypoxia. So diffusion hypoxia is your nitrous oxide has low blood solubility. So when the administration of the nitrous oxide is discontinued, it rapidly diffuses from the blood into the alveoli. So you have to remember that pathway from where, like from the brain, when they are withdrawn, when the administration is discontinued, they will be coming to the blood compartment and then to the alveoli, that is to the lungs, and through the expired mixture of gases, they will be expired out. Okay, so in that process, what is there is that because your nitrous oxide is so much less soluble in the blood, there will be rushing out of the nitrous oxide from the blood compartment into the alveolar compartment so much faster that they will be causing the marked reduction of the partial pressure of the other gases, that will be your oxygen also. Okay, and that causes a kind of situation where, because of the differences of the partial pressure, they will have a hypoxia kind of situation. And because they are caused because your nitrous oxide is being rushing out too faster from your blood compartment to the alveolar compartment, so that will cause the hypoxic effect. And since this is because of the diffusion of the nitrous oxide very much way faster than expected, okay, that is called as your diffusion hypoxia. So if you see in the figure also, okay, so this is for the onset of action. Nitrous oxide will be rushing. They have faster onset of action. They will be going into the blood compartment for a very faster period. Okay, in that also from the high partial pressure of nitrous oxygen to the low partial pressure while the induction is there. But we are talking about the discontinuation of the nitrous oxide. So from the areas of the brain, when the nitrous oxide are discontinued from these areas of the brain, they will be running very much faster from your uh, blood compartment to the nitrous oxide, because they have a faster faster recovery also. Okay, and in that process, from the blood compartment, they will be coming to the alveolar compartment very much faster. Okay, that will kind of because the nitrous oxide will be rushing into the alveolar compartment so much faster that it will kind of affect the partial pressure of other gaseous mixture along with their oxygen, okay, and that will cause a hypoxic effect. And this is caused because of diffusion from your nitrous oxide from higher partial pressure to the lower partial pressure while they are discontinued. Therefore, they are called as your diffusion hypoxia. So, am I clear or not? Is this clear?
Clear, ma'am.
Okay. So, lastly, coming to the adverse effects of inhaled anesthetics. Okay, so in the acute toxicity, there can be a nephrotoxic effect as well as hematotoxic. Also, there is the hepatotoxic effects shown by some of the drugs. So, mainly your drugs called as enflurane and sevoflurane are nephrotoxic in nature. Okay, so the nitrous oxide in the hematotoxicity, this is mainly shown with the nitrous oxide. If you remember, I've also listed nitrous oxide toxicity as the megaloblastic anemia. Okay, so there is this enzyme called as methionine synthase, okay, which it will be required uh, for the synthesis of the blood cells. Okay, and when this the prolonged exposure of the drug, that is nitrous oxide, actually decreases this activity of this enzyme called as methionine synthase, because of which your blood cells production will fail and they will land up in megaloblastic anemia. So it is mainly used in the dentistry because these are used as a sole anesthetic agent for the dental procedures. Okay, and so RICS is mainly for your dental personals, like it is one of the occupational hazard for them, because if they are prolonged exposed to the nitrous oxide in not well ventilated room, then the risk of having the having the megaloblastic anemia as an occupational hazard can be seen with the drug nitrous oxide. So next important adverse effect is malignant hyperthermia, which was mainly related to the drug known as, what was the name of the drug?
Halogen.
Allothane. Okay. So I've already explained briefly, also with briefly. Okay, so it's not seen in all the individuals. So there are certain group of genetic abnormalities seen in some of the patient. You can relate it with the pharmacogenetics. Okay, so this is kind of your heritable genetic disorder of the skeletal muscle that occurs in susceptible individuals exposed to the volatile anesthetics, mainly your halothane and sevoflurane. Okay, so depolarizing muscle relaxant succinylcholine, because while using the anesthesia during surgeries, if you need more of skeletal muscle relaxants, we are using skeletal muscle relaxants like succinylcholine, then it can even trigger, there will be additive effect of the adverse effect too. Okay, when you combine the anesthetic like halothane or sevoflurane with succinylcholine, so that will trigger the effect. Okay, so there is an abnormality in a receptor known as a ryanodine receptor, okay, which is a calcium release channel that is present in sarcoplasmic reticulum. So because of this abnormality, what happens is that there will be more of the release of the intracellular calcium levels, and when there is much higher concentration of the calcium in the cell, okay, in the skeletal muscles mainly, they cause elevated temperature. That's why the thing called as hyperthermia is there. Okay, malignant hyperthermia. So they also cause increased muscle metabolism. They can land up in acidosis. There will be muscle rigidity. There will be destruction of the muscle cells, rhabdomyolysis, and even cardiovascular cells can get affected. So this is a situation where this is very fatal situation and kind of emergency, life-threatening medical condition. So always we have to be prepared of these adverse effects when we use the drugs like halothane along with succinylchlorine or sevoflurane. Okay, but the good thing is that with this toxicity or with this fatal, life-threatening emergency situation, we also know the drug which can reverse the situation. Okay, and you also have to remember the name of this drug which can reverse the situation, and the name of the drug is dantrolene. Okay, what they do is that these drugs they reduce the calcium release from sarcoplasmic reticulum, which is the main culprit behind the malignant hyperthermia. Okay, okay, so this is again represented in the figure here. So this is mainly seen in the susceptible group of individuals where it is a kind of genetic and heritable kind of thing, not seen in every individual. Okay, so there is this ryanodine receptor you can see in the sarcoplasmic reticulum here. So there is this receptor called as ryanodine receptor. Okay, so in this genetically abnormal individuals, there will be kind of abnormality in these ryanodine receptors, which will kind of result into the abnormal release of, there will be no control of release of calcium into the cell. So there will be more and more release of the calcium into the cell, because of which, because of increased calcium concentration in the cells, they can start causing muscle rigidity. They will be increasing the muscle metabolism. Again, calcium will be utilized for all these things, because of which they can land up in acidosis, and there also is hyperthermia, which there will be more increased heat production. Okay, so this is all combined together, is called as your malignant hyperthermia. So this is a medical emergency situation, life-threatening and even fatal emergency situation. So you should be prepared for the situation. And what is the drug used to reverse this condition called as malignant hyperthermia? Dantrolene. Okay, so please remember that name. Okay, the name is dantrolene. So next is hepatotoxic effects that is seen with the drug again, the drug called as halothane. Okay, so please go and revise your hepatotoxic drugs. So the mechanism for halothane hepatitis will be illustrated there. Okay, so they can be the direct toxic effect also, and also mediated through your immune response that is produced through the metabolites when the liver metabolizes this halothane. Okay, so because of immune response also and direct toxicity also, a hepatotoxic effect can be seen. So chronic toxicity, longer toxicity, when like is there, they can cause mutagenicity. Even teratogenic effect can be there with the drugs, and also they can show carcinogenic effect. Okay, so I think this is the, so that will be end